Our mission is to provide trustworthy and reliable information, to fund research, and to advocate and support people living with headache. And each session, we've been running through one of these activities that we've been active on during the year. And so tonight, we just wanted to highlight some of the media that we've had over the year and more recently as well. With the Queen's passing, we haven't had as much PR as we would have liked for Migraine and Headache Awareness Week, but we have been active and advocating on your behalf across different channels, including National 9 News, ABC Radio, and other places. So if you're wondering if you're in the right place, well, if you have migraine or headache, if you are a parent, partner, or caregiver, you're very welcome. If you'd like to connect with others like yourself, we have a support group on Facebook, if that's a social media channel that you use. And if you want to ask a question, then you are absolutely in the right place. So let's move to our speaker, Dr. Bronwyn Jenkins. She's the president of the Australian and New Zealand Headache Society. She's a neurologist with a subspecialty interest in headache. She speaks internationally on the subject. She's participated and helped facilitate a headache master school program at the University of Sydney. She is a member of several organizations, including the International Headache Society. She has a leadership position there on the board recently. It's hard to find someone who has more credentials than Dr. Jenkins does in Australia for headache and migraine. So we're really privileged to have her tonight. And with that, we will go into her presentation.
Thanks for joining us with Headache Week. It's fantastic to catch up each year. This year, I have the topic of 2022 research findings on headache and migraine. And we're going to try and keep it really relevant to the Australian population and base things on what we've found around our recent COVID pandemic. So some of you may have participated in and known about the survey we did in 2020, and now we're presenting to you the repeat survey that we did in 2022 to see how this was affecting Australians living with migraine. And then I'm going to go over a brief overview of some of the latest international research in headache and migraine around these topics. So I did this in collaboration with Headache and Migraine Australia, and a huge appreciation to Carl Cincinnato, who really was integral in organising this second part of the survey. We know that migraine attacks are affected by lifestyle factors, and it's usually measured within an individual with a headache diary at one point in time. But we had such a sudden dramatic change in lifestyle with the COVID-19 pandemic and lockdowns, as well as the effects on lifestyle, employment, even the economy, that we wanted to assess whether this altered migraine attack frequency, severity, or impact. There was a sudden closure of all non-essential services in 2020, which allowed us to consider how working from home might affect those living with migraine in Australia, which is a really interesting area to look at about what we should be looking for in modifying the workplace. And furthermore, we thought that the increase in COVID infection rates this year may have had a negative impact on health, including headache as a symptom, and particularly in our migraine population. So we repeated the survey in August of this year. So we tried to keep the survey questions similar, except the duration of recall required. In the first one, where it was a short duration from the months prior to the lockdown. But this time it was trying to compare it to the year before in the same season and month. And we had an overlap of 82% of voluntary responders answering both surveys. So it was a very similar population that we surveyed. So these are the results. We had 683 respondents, which is a fantastic response. And we're really appreciative to all the people that took the time. And 98% of those had migraine. We had a disproportionate female responders number, which is the case in a lot of trials. And obviously the working age group are mostly female, but 89% is still very high. And almost a third were diagnosed by the GP, as you'd expect. But sadly, almost 2/3 were diagnosed by a specialist. And you would think that migraine was being picked up in primary care. So this is something to improve. By now, 90% of our responders had used telehealth, and 50% found it as effective as face-to-face appointments. So of those receiving in-person treatments, by this we're meaning injectables like Botox perhaps, which was 75% of the total, so quite a severe group, 82% had disruptions to their in-person treatments, which was higher than the 36% in the first months of the COVID pandemic. of those that switched from Botox, most of them were switched to a CGRP monoclonal antibody therapy to be able to self-inject, which is one step closer to self-management. And 48% of those receiving Botox specifically had issues with their treatments during that COVID pandemic time. The medications, as you know, have had some disruptions to supply with transporting them from overseas and whatnot, and 41% had difficulties accessing medications from this survey. So the increase in migraine was actually of less magnitude now 2 years in than with the initial lockdown in 2020, which I must say was a bit surprising to me. Pleasant surprise though. So that most people were similar in frequency of their migraine days. 41% were unchanged compared to the number of 37% being increased and 22% actually improved. Most had a similar severity. Again, 46% were unchanged compared to a low number of increased and improved. And most had a similar impact as well compared to the same month the year before, 47% unchanged. So that's good compared to the increase we saw with the sudden change in lifestyle in 2020. And then we tried to look at what were the predictive things in those that did not as well and those that hopefully did better. So this is columns of different lifestyle factors. And the first more red column is the number that had an increased frequency of migraine in percentages. And the overall rates in percentages is the orange column next to it. So if the red column's bigger, it means that it had a greater effect in those that were worse. So the greatest association was with mood. The first column is increased anxiety, and the third bunch of columns there is increased depression, and also sleep. So that second group of columns is the group that were less well rested. So there was sort of 17 to 18% difference from the overall rates of these being a factor. Then there was a proportion that weren't as good also if they did less exercise. So I think the increased anxiety, lower mood fits with what we know, that stress is one of the most common triggers of migraine, is well worth and very rewarding in its management, which we'll talk about a bit later. So I consider this slide to be the glass half empty slide. So moving on to more positive things, how can we learn positive things from this survey? And this is a glass half full slide. So same sort of thing. This is now the decreased frequency group on the left in reddish colour, and compared to the overall rates in orange. So having decreased anxiety or decreased depression, improvements in these two factors were the most powerful for improving frequency of migraine if they're a direct association. And also, interestingly, having a less processed diet. Now that possibly has a whole lot of other factors in lifestyle, such as other factors of health, regular meals, a routine, perhaps even hydration. So I think it's simplistic to ask whether they had a processed or non-processed diet, but I think it's still interesting to look at the impact, because it's very surprising to me, with such a direct relation of alcohol being a trigger for those living with migraine, that alcohol didn't really factor in either of these groups that were worse or better. And that sleep wasn't as strong a factor as I would expect either in this improved group. So employment. Unfortunately, this is a glass half empty slide. 63% of our group were working, but 11% were unable to work due to health. And this had increased from 6% in 2020. So some people I see in my clinical practice have commented that COVID's brought the rest of the world back to our sort of regulated environment, as it were, being based from home. And I thought there might be some more positives to tell you about, but that's a really unacceptable rate of unemployment and compares very poorly to the overall national figures of unemployment of 3.4%. And it parallels the fact that migraine is a highly burdensome disorder that hits people in their working age, and really we need more input to increase the status and increase the care in this area. So there was an interesting group that were still working from home. There were 288 of our responders this time around, and so this is 45%, which had decreased a bit from 54% 2 years ago. 70% had a better work-life balance that were working from home. 68% were less troubled by light and or noise. It was under their control. They no longer had to sit facing out the glary window or under a flickering light. 55% felt more productive. 44% were working more. That's a negative. But it's good you could. And 36% had a better setup for posture by now. So these are all positive things, but surprisingly, the frequency of migraine was similar to the overall group. So in this group, we had 22% with less frequent, 35% with more frequent migraine in working from home group, compared to 23 and 37%. You can see how similar the rates were. So I would have thought that lifestyle factors of controlling the work environment from home, having that flexibility, ability to rest when you have the onset of a migraine, and even take your acute medications more regularly in safe use, I would have thought that those things would have correlated to a bigger improvement in migraine disorder. So this is a complete aside. I find it useful to talk about what have been the things in the literature suggested for managing migraine in the workplace. And the Migraine Trust, MTIS, suggests that reasonable adjustments might include the employer disregarding a reasonable amount of disability-related sickness absence, some flexibility of work to manage time and reduce stress, which I would have thought we'd get from working from home, particularly now the kids are back at school. And also changes to the work environment, like good support for posture, having the desk away from window glare and so on. They've got a useful website, particularly for the working from home group, and they suggest you set yourself off with time off when you need it, maintaining a routine. So, for instance, if you used to have a walk in your commute, to try and still encompass an early morning walk and evening walk instead of skipping your exercise altogether. Taking regular breaks, and with this increase in computer world, it's important to rest the eyes as much as you don't have a break from your work screen to have more time on your other screens, and just resting the eyes can be quite helpful. And dealing with any screen issues, so anti-glare screens or covers, adjusting the brightness, using a higher screen refresh rate, changing the view mode. So you can see that they give quite detailed suggestions. And ensure that you continue to have access to water and snacks with regular intake that's healthy, rather than becoming dehydrated and not looking after your self-care, because it can be a bit constant when work suddenly moves into the home. So, changes in Australians living with migraine and headache since the increase in COVID infections. So we specifically asked about rates of infection, and 91% of this group had been tested for COVID, 54% were confirmed as positive for COVID, and a further 2% thought they might have been infected without formal diagnosis. Of this, only 2.5% were hospitalised. Now, keeping in mind we had the milder versions of COVID strains when we had the peak of infections. Since COVID infection, almost 60% were similar in migraine and headache frequency, but almost 40% had an increase in migraine and headache days. Of that, some of them were for a week or a month, but there was 7% that were up to 3 months, and there was 17% that after 3 months were still having persisting increased headache or migraine days, which of course is not good. Surprisingly, this is not completely different to figures that have been quoted in the media, around 15% of the general population. So we found this useful to have a cohort to show that adapting to the initial change in lifestyle, we've always thought it's about change, and in the converse, it's about routine, helping people. That now that things had stabilised and people know where they're at, the majority were maintaining a similar frequency of migraine as we adapt to living with COVID. Anxiety and depression had the strongest correlation in both directions to either worsening or improving frequency, and so should remain a well-managed factor and a priority in migraine disorder whenever present. And access to treatments were affected most for those requiring in-person treatments. The rates of being unemployed are unacceptably higher than the general population and seem to be on the increase, more alarmingly. And the working from home subgroup recognised the benefits in managing their triggers, but their rates of migraine remain similar to the overall group. So hopefully we can remember what these positive lifestyle changes are and continue to achieve them. So moving on to other research advances, I would think, this year, just to update you. I know you're a highly informed group and have had other talks this week. So I'm going to focus on the factors we've just discussed, the lifestyle and comorbid mood disorders, the actual direct effect of COVID, and then that interesting topic of persistent headache, as well as migraine disorders. So starting off with the lifestyle and comorbid mood disorders in migraine. A huge acknowledgement to this very clever clinician in America, Dr. Rebecca Wells. She gave such a good talk at our Australian New Zealand Headache Society for Professionals, the scientific meeting, that I've showing you some of her slides here that summarise the literature. So there's really good evidence, and it's been for some time that we've known these things work. Biofeedback, cognitive behavioural therapy, and relaxation techniques all have grade A evidence. It's quite hard to access this, though, at the moment. So that's why I'll show you some other options, because so many people need psychology input, and there's such, difficulty maintaining access to care for everyone. So the effects are quite large, and it's similar to drug trials. So really, we shouldn't always be looking for the best new drug. We should also be doing good self-care. It's useful in combination with medications, so it's not an either or. Don't do one or the other. Do everything as well as we can. And whilst there'd been some systematic reviews of these very different studies that showed responder rates, it really didn't consistently show an improved headache frequency, although there were quality of life or function improvements. So it's a bit of a mixed bag when you put them all together in reviews. The thing I found most useful was her study that she was involved in, which was a randomized clinical trial, so less prone to bias because of that, that way of design. And their primary endpoint was migraine day reduction. And unfortunately, that was similar in, not unfortunately, it was similar in both groups. So they had mindfulness meditation versus just headache education for adults with migraine. So both of these are useful, but in the mindfulness-based stress reduction, they improved in disability, in quality of life, self-efficacy, pain, catastrophizing, and depression. But what was even more interesting was the effects of this 8-week intervention persisted out to 36 weeks of follow-up. Then there was a much briefer intervention of a single online mindfulness intervention, so online being accessible even during pandemics and also much easier to roll out. And it reduced momentary anxiety in almost 80%, as well as improving other secondary outcomes. So you can see it shifting from worse scores of very much down to the majority having a little or not at all in those measurements. So there is a scientific basis for mindfulness that's beyond the scope of this talk. There's been the use of functional imaging to follow the changes in brain activation following cognitive behavioural therapy, for instance, and also actually measuring quantitatively the pain appraisal with a stimulus going down with these strategies. So don't feel like you're just being shirked off or minimised if your neurologist suggests that these management options are very powerful and helpful. So then moving on to nutrition. And again, we had an excellent talk from Margaret Slavin at our recent scientific meeting. And I was actually going to ask someone who'd written the latest review, who was a neurologist, on the role of diet in migraine. But when I read the actual review article from this world-leading expert, it didn't even mention the most highly significant recent trials. So I really thought that Margaret was a much more wide, rounded basis for what was evidence-based. And it's not so much about diet and exclusions, but more about good nutrition, perhaps having a therapeutic benefit. So she listed off all the different diets, and again, out of the scope of this talk today, and we've talked about this in previous years, but really the omega-3, omega-6 study and the ketogenic studies are the most interest. So looking at the omega-3 up in the top corners, there's that little healthy platter of the types of foods you would have, including a bit of fish and lots of legumes and those sorts of dietary things. And there's, these huge long lists of what they actually had in their protocol. And basically, there was a benefit in both groups that had the higher omega-3 and the L6 ratios without any change to their quality of life scores. I find this quite interesting that both of these sorts of types of diets I'm going to show to you didn't improve the quality of life score, because I do see some people, and it's the same in my own practice, getting tied up in knots about diets that are so almost antisocial. It then limits their ability to enjoy things freely without a sense of guilt or control over the migraine disorder. So she was thinking that it would be useful to suggest this for the person who's ready. And ketogenic is similarly complex. So again, if that's their preference and they're ready to have a very rigid diet that can't be broken here, there, and everywhere, then these can be considered. But they usually require dietitian input, or especially trained neurologists, which I don't think I'm unaware of who can do these in Australia currently. But for everyone, we should be generally following the principles of a healthy diet, eating lots of fruits and vegetables, limiting ultra-processed foods that are high in sugars, solid fats, and salts. And I liked her point that, don't feel that there's any sense of blame that we're causing our migraine disorder. So moving on to COVID and headache. There was an interesting study of 31 patients from a tertiary headache centre, and they were looking at the type of headache. So it's a recognised symptom of COVID-19. It's very different from having a migraine disorder. It is closely linked to the other symptoms of COVID, but it's not associated with the increased rates of pneumonia or hospitalisation as such. And so having headache was early on considered to be slightly protective for your risk of hospitalisation, which is interesting, and usually lasts 2 weeks, which is in keeping with our group having most of the increased headache around the first 2 weeks. But it can extend after 3 months in 19% of this study. And remember, ours was 17%. So I thought that was, very qualifying that this is not unheard of. It's sad, but it's not unheard of. So this study looked also from a retrospective case review of the individuals, and 81% had a previous history of headache, and 65% after this illness with COVID had chronified into chronic migraine, whereas only 16% of that group were classified as having chronic migraine prior to their COVID infection. So we're going to see a lot more chronic migraine in people living with migraine disease if we don't try and limit the transmission of this virus. And obviously it will change over time with population and herd immunity, as well as varying strains. And so interestingly, they also had a drop-off in full-time employment in their group, and they looked at who'd been started on migraine preventive therapies, which did still work in this group in improving the frequency and severity of headaches. So I thought that was useful for our practice. And then headache associated with COVID-19 again, and this time from a European group, and it was more of a narrative review, and it was looking at who gets this. So it was the younger group with them, previous headache disorders again, and again, headache was associated with the other features, the lack of smell, taste, and muscle aches. They actually classified as bilateral, moderate to severe, but in fact, the other paper just before had noticed unilateral or any type of headache. And then they talked through the theoretical causes. It could be direct viral injury, an inflammatory process. It could be low oxygen, a clotting disorder, or even endothelial involvement of this, very sticky virus. And they used common analgesics and anti-inflammatories. And many of my patients have told me that their triptan medication doesn't work for that viral headache that they have acutely. So then persistent headaches after viral infection. And so there's a talk by Dr. Ray on Wednesday of this week about new daily persistent headache. So it's certainly not to talk about all the ins and outs of that, but just to touch up on what's the role of infection in this group. We had a lovely talk from Professor Shujun Wang from Taiwan, so big acknowledgement to him. because he'd done this update of new daily persistent headache in the last year in the literature. So systemic infection is actually the trigger for a new daily persistent headache in about 10%, whereas a stressful life event is more commonly the trigger. But it is already recognised that the COVID virus is one of the emerging infectious diseases that might be linked, and there's hopes that it might lead to some further information in this subgroup. And in fact, he went on in his talk to tell us how important it is to classify this headache disorder properly. So there's been a large study of new daily persistent headache recently, again in the last year. So I'm trying to take papers from the last year. But it had a few limitations. And so randomized control trials are lacking regarding treatment in general. There's been, at best, case series studies, which is just sort of, we took a group of patients and this is what we noticed, and blocks, Botox, infusions, steroids, or some of the migraine preventives are suggested as helpful. So for people with a persistent headache, they'll usually go through a pathway of trying single or combinations of these things. And of particular interest, the CGRP therapies, despite their integral role in migraine disorder, still have promise in refractory headache. But the study looking at this didn't separate the chronic migraine group from the new daily persistent headache group, which was only 10% of the cohort. So we need really clear definitions to have really good data and studies from these groups. So really our future perspectives are to get better studies, precise subclassifications rather than lumping everyone just based on frequency of a headache into the same group. And then we can look at outcome predictors, and there'll be a lot of science that's needed behind understanding this group, which is separate to the migraine group. And we really need high quality randomized control trials once we've classified them correctly, because sadly it's not an uncommon disorder. So on to our local migraine updates. What are we doing research-wise in Australia? So I really wanted to let you know that there is a HEAD study. It's an Australian headache epidemiology data study. It's a pilot study because of the limitations of cost and funding as to how much we could do, but it'll be really exciting to have robust Australian data of epidemiology of migraine. So it's going to be a questionnaire sent out to 19,500 households. So rather than our survey, which is a biased group of very motivated but highly informed and usually more severely affected people living with migraine disorder, this will be like your census, where it's sent out, and it's a very detailed but also validated questionnaire that's been used in the other burden of disease studies around the world, which we embarrassingly are a big blank page, or when they have the map of all the countries that have participated in these sorts of high quality epidemiology studies, we lack high quality studies. So this will be really powerful for using for future funding, elevation of understanding how important migraine is in our local region, because we can't just rely on international data of different demographic populations. So a big shout out to Emma Foster and the team who are running this through several centres, as well as they were awarded the Brain Foundation research study to help them with this. It will be really interesting to see the results. Then on to, what's the latest things in migraine? Well, I think we've always had these concepts of the functional imaging lighting up to try and tell us what's chicken and egg, where does this get generated from, what are the common underlying mechanisms structurally in migraine disorder. And I thought this was particularly interesting about the complex brain disorder where there's altered connectivity. So they looked at migraine without aura, because aura complicates things further, versus healthy controls, and looked at where there were more connections happening in that person without aura with migraine. And so they found that they had a higher local and global network efficiency of those neurons and clustering coefficient. But they also found that the posterior cingulate cortex and inferior parietal lobe, so different parts of the brain, assumed the hub role, whilst the fronto-orbital cortex and the visual cortex lost the hub role in the group with migraine. So we're understanding more and more with advancing technology above and beyond just the neurotransmitters that are being studied in the labs. Christina Tassarelli presented this information. So she's the president of the International Headache Society and a magnificent woman, really clever clinician and scientist. So she still recognised that the holistic approach is required for this lifelong complex disease. So I think all these decades on, it's good to see that the biopsychosocial model is still important, as well as understanding newer therapies and how they interact with the biology. So we really need individual biomarkers, genomics, pharmacogenomics, markers even in testing of neurophysiology or imaging. But we need further basic science, and we need good epidemiology, which we're hopefully getting in Australia. And also it would be helpful to have some global treatment guidelines, were her suggestions. So in this last year, since we all last caught up, there's been many real-world studies of new therapies, and they can be a little biased in their selection of cases because you keep following the responders, but they really have a recognised important role in understanding the safety as well as the utility in a much more severely affected group in the real world that haven't been nicely selected out to be neat, simple, early patients with migraine that fit into a neat trial. So there'll be much more talk about the new therapies by Dr. Ella, or has been much more talk on Monday, and people can look at those on the website if they miss that. But I thought this was good to look at the CGRP monoclonal antibodies response at 6 months in this real world study, and they found that 61% no longer had medication overuse by definition at 6 months. And so it markedly decreases the requirement for triptans in the responders. And it was as effective in chronic migraine patients with or without medication overuse, which is new because usually we have to deal with the medication overuse before we get responsiveness for other oral preventives or sometimes Botox. And then another one looking at the treatment of medication overuse from our Danish colleagues. Louise Carlson did her PhD in this. And so this showed that there are 4 lines. So they looked at just withdrawing the medication, withdrawing it plus a preventive, preventive plus a potential withdrawal later. And the black line is the overall group. And you can see that there's a slight win for the withdrawal plus a preventive. So really bridge with a preventive to decrease the severity whilst also getting rid of the overall overused medication. And with that, you get a steep drop off in the frequency of the headache days, which you can see here in the first weeks. But even better, you get a sustained response when you look out to 12 months. So again, reiterating the importance of managing medication overuse. So my conclusions for tonight are that despite the COVID-19 pandemic, we've got an increase in research publications and education continuing, albeit with a bit more of an online focus. And so we're still aiming to improve management of migraine and other headache disorders. Headache is a symptom of COVID rather than its own disease. But it is affecting those living with migraine disorder already, and it's more commonly occurring in that group with considerable differences in how we characterise this in the small case series so far. So we need better studies. Further studies of primary and secondary persistent headache disorders is recommended with clearer definitions and study design. And I don't think we should forget the power of managing comorbid anxiety and depression as very clearly associated factors in worsening or improvement in headache and migraine in those living with migraine disorder. And it was interesting that these remained the most important factors despite the other routine and the lack of change, showing some improvements in further deterioration and further worsening. So there are some positive aspects of the COVID pandemic, our ability to learn things about the flexibility of working from home and lifestyle choices such as healthy diet and those people that exercise more, but also access to online resources. I mean, it's amazing to be in the era where we can have online mindfulness, or we can have different apps that we can just tap into till we find something that resonates with us rather than something's been chosen for us by one clinician. So hopefully we continue to make these improvements in our lifestyle after all these learnings in the COVID-19 pandemic, and something positive comes out of these difficult years. Thank you so much for your time, and I look forward to your questions.
Thank you very much, Dr. Jenkins, for that wonderful presentation. You covered a lot of ground. We've got a bunch of questions, and we'll jump straight in. If you haven't asked a question or you've been holding on to it, feel free to submit it now, and we'll be reviewing those. We had a couple of people asking about the AHEAD study. Is that still open and allowing participants? And if so, how do people get involved?
Yeah, so I think with an epidemiology study, it's always a random sample. And I agreed with the comments that we should really have migraine in the census. When they added new items for the first time in many years this time round, I was thinking, oh, I wonder if we can get migraine in there. But it is very difficult to do such a large sample and to have everyone's sort of health related questions in there. But for this specific study of the AHEAD, and I apologise, that version of slides didn't have all the details, which will be on the web version later. It's going to be a random sample that we can't bias by asking people to participate. So we're not looking at severity of the migraine for the group that already have confirmed migraine or other headache disorders. We want to know what is the prevalence in a cohort in the population that have a high rate of response. So it's a reliable sample to know that they've actually got a headache disorder and what prevalence that is in a normal community.
Right. And do you know if they're covering cluster headache in that?
No, I think it's specific to migraine.
Okay. So you spoke about working from home. Sharon wanted to know, for those of us who aren't in front of a computer all day or not working in an office, were there any insights that came out in the research?
Yeah, I thought that was a good question. And if I had my time again, we'd ask more specifically about that. I guess the people that aren't working behind a computer, they're the ones that are working in shops, out in the open, construction, hospitals. They were the ones that weren't locked down. So they're the not working from home group. So they had very similar rates overall, but we didn't have the scope or the numbers to look at specific industries of work. We asked them quite a lot of questions about why they were or weren't working, and a lot about their status, which wasn't us being nosy. It was literally to see whether single parents with children at home were struggling more, you know, factors that were standing out as major things. And I've only reported back on the things that we found were of most interest of it and looking to be of any sort of shift in change. So we really didn't look, but we could see that overall the working from home, the computer-based population that was told if you can stay home, were similar this time round to the group that if you can't work from home, keep going to work, even when we had the higher rates of infection. They were doing very similarly in their frequency of migraine.
I had a few questions about the dietary findings that you spoke about. We had a comment from Jenny who said that she went on the keto diet. She actually got worse. I would imagine the keto diet is not for everyone. I've tried it. It's one of the most difficult diets I've ever done. I did have a positive result initially, but then I had an abnormal or an elevated liver enzyme, had to stop, according to my GP.
Yeah, so changing these things too quickly can worsen things. In fact, the keto diet's been looked at for improving hepatic function. And I would use it more readily in really tricky epilepsy cases because I think for migraine, there's probably simpler diets that still have some improvements. And so that's why we ask that question about processed diets, because I think if you have an overall healthy diet and you're less introspective, less stressed about trying to live less life, it's a positive thing. So it's good to try these diets if you've got the motivation, the ability and access to a dietitian to help step through and do it properly. But I'm sure a massive change in diet can make some people feel worse. Yeah. So overall, it's definitely proof in the literature, but that doesn't mean in any of the studies that everyone gets better. You know, look at our new therapies. Some people get worse on the new therapies or have side effects, or moreover, they don't improve. And so with the natural history, they're potentially getting worse as well. So it's good for the responders and not so good for the non-responders. But even amongst that sort of optimism of response rate, it's really got to be something you've got the time and energy for, because it doesn't, it's not the main treatment, I would say, of migraine. And there's better things of there's as good things of having, nurturing your mind and having that time out with meditation, mindfulness. I'm glad it's reminded you to go back to your meditation, Carl. I think we all have to take a leaf out of that book. But also hydration, regular routine, regular meals, good sleep, like be kind to yourself, because there's definitely some benefit in that. And sometimes these diets are really quite tricky to introduce into a family or even individually. You'll stop getting asked out to restaurant dinners, that's for sure.
One thing I have started doing with my diet, and Erin sort of suggested this in one of her comments, was just trying to be a little bit more sensible, minimizing processed food. There's no diet that has been proven that works for everyone, but this study about the omega-6s is really promising, and it's just eating a little bit more fish or omega high food, like foods high in omega-6.
Yeah, so the omega-3, so whether it was mainly the omega-3, I think, and
yes, apologies.
Whether they had the other component didn't make as much difference. And when you look at that dietary plate, it's like, yeah, I could eat those foods. It's a little bit more doable. I'm not a dietitian. I wanted to be a dietitian, but that's beside the point. But I'm not a dietitian. And so I recognize I'm a neurologist and I do neurology really well, but I don't do dietetics really well. But some of my patients have asked for the details, and there is a research protocol for that diet. Perhaps, if you have a resources page, that could be added up. It's a bit clunky to read, but it tells them exactly what the diet was that showed that significant reduction in migraine in the UK study.
We had another question from Julie asking if you thought that migraine and headache is also related to weight gain. She's noticed that her attacks have become worse since she's put on weight.
Yeah, so there's a couple of things hidden in that. Certainly, Richard Lipton and his groups have recognised that being overweight or obese is definitely a risk factor for having chronic migraine, chronification of your migraine disorder. And so it's a bit vague to tell people to just not be overweight, though. The second thing, though, is migraine headache can be a symptom of higher pressure. So sometimes people get idiopathic intracranial hypertension and have a very migrainous headache. So if they haven't had medical review, they need to make sure that their optic discs, their eyes are normal without signs of pressure at a minimum. And the third thing is it's sort of a self-fulfilling thing. If you're so sick with migraine you can't exercise and you're sedentary, then it's easier to put on weight. And also there's a lot of interest now in the metabolic disorders of how some groups of people have abnormal neuroendocrine reasons for gaining weight. And the most work has been done by Alexandra Sinclair in the UK in idiopathic intracranial hypertension, that high pressure one, because they're mostly overweight ladies. And there's huge changes in that group, analogous to the polycystic ovarian syndrome group. So yes, weight does correlate with migraine, but not so neatly. It's not so causal that if you lose weight, you'll have less migraine or less medication overuse or any of these things, unfortunately. But it is definitely something I mentioned to patients that healthy diet, regular low-grade exercise when they can, when they don't have a migraine at that time, and also maintenance of healthy body weight, as well as all those other lifestyle factors, is probably useful.
Rhonda wanted to know what your thoughts were about caffeine, taking those for her migraine attacks. She has coffee when she has a migraine or headache coming on, and she takes it with Panadol and a cold pack and with some rest.
I think she's saving herself a lot of money. I think that's genius. Anything that helps the migraine so quickly, though, in withdrawal is terrible. So caffeine is known to help migraine at the time. And so if you're taking it once every few days for a migraine, perfect, figured it out. And that's why it's in combination, things. We've got Panadol Extra now hitting our shores. So it's been known for a long time that can help clinically. But the problem is, in the supplements we have, even the gym supplements, the doses are really high. So if you take them every day, if you're taking them every second day and then it gradually increases to every day, you get a mini withdrawal, no matter how clever you are titrating your caffeine while you're sleeping overnight. And you might start to get wake-up headaches or even more daytime headaches. So I usually limit caffeine use to 1 coffee a day. My kinder Melbourne colleagues often allow 2. It's meant to be dose dependent, but that comes from the caffeine withdrawal headache sort of definition, but I think that it's something to have, but not have so regularly in high doses, because certainly that's one of the acquired factors of why adults have more frequent migraine than they should have. So I see some people coming in, they're having 4 or 6 coffees a day. You can get a really marked reduction if you gradually decrease it. But I have learned over the years not to stop it suddenly, because without doubt, the person will call me the next week in tears, what should I do? And I will tell them to have a coffee. So just gradually, half a cup instead of a full cup, less cups, less strong. When you're going to your local cafe, a large coffee could have 2 or 3 shots. They want your business tomorrow and the next day beyond. So make sure you're just not having that, increased dosing that we're getting with modern life.
I've actually found shifting to teas to be quite helpful, particularly in winter. And black tea still has caffeine, but it doesn't give me at least the same sort of jittery sort of sensation now that I might have with a coffee. So
it's a much smaller amount. And I don't worry about someone who's having 3 teas, but I do worry about someone who's having 2 strong coffees, because that usually means double shot, particularly if they're purchased. But yeah, it's a good little trick to have a tea instead. But the craziest thing is Coke Zero has the most caffeine of all of them. It sounds so innocuous and sort of gentle. I'll just have a Coke Zero. It tastes like Coke, but it's not really Coke. But they've got the caffeine in it to get you coming back. I hope no one from Coke is online.
We had a question about cognitive behavioral therapy, CPD. How does that actually work? Jen wanted to know, and she was wondering if it's just sort of learning to adjust.
So this is where I'm a neurologist, not a CBT therapist. I lament all the time, I wish I could do assessments like a physio of the neck. I wish I could do mindfulness techniques like even that Dr. Rebecca Wells that I was mentioning. But I've learned a long time ago to keep being good at what I do and let the other team members do it. So having never had CBT, I don't know what a CBT process is in detail. But it's a very recognized, standardized treatment. And I think a lot of our pain programs are just accepting the pain, but I think cognitive behavioral therapy is more complex than that. So if you do the chronic pain management course or read a book like Manage Your Pain, it'll teach you to just sit with the pain. But I think cognitive behavioral therapy will be much more of a psychological technique to decrease any anxiety or fight or flight responses and those things as well.
Yeah. And I mean, speaking from personal experience, when I was chronic, I had quite a significant amount of catastrophization. So when I had an attack coming on, it was like the sky was falling. I would almost have like a panic attack. I'd have high levels of anxiety. And as I was getting better, it took me a while to realize, but I would have that same emotional reaction, even though the migraine was like a 3 or a 4 out of 10 versus an 8 or a 9, which it was. And cognitive behavioral therapy allowed me to kind of recognize that and then recalibrate and have a bit more of a sensible sort of reaction to it. So I think, it can be quite helpful. I quite sort of like the idea of CBT in children because it gives them this skill that they can then take with them later in life and apply it to other things.
I know. Why aren't they doing it at school? It boggles my mind, particularly during COVID. Surely that should have crept into the curriculum. But there was a nice little survey about 3 years ago in migraine. It was a little self-selected. There was people that had failed a couple of preventives. But of that group, 70% were fearful of the next attack. So we have this whole intractable burden, and the catastrophization of as soon as the headache starts is even worse, but it's really common. So I think I tell all my patients about all of these things. There are a few online tonight. It's nice to see you guys online. Because I'm not singling people out as to whether they're anxious types or not. It's not minimizing the migraine disorder itself, but it really is a useful target that we can modify. We can't change barometric pressure. We can't change the external stresses foisted on us in this pandemic, but we can change our emotional reaction to it. And that makes a big difference, I think, in the migraine attacks.
Talking about some of the new research, we had Luke who wanted to know about whether there's been any research for new daily persistent headache or any sort of treatments that are coming down through the pipeline that you might know about.
No. New daily persistent headache is the area that needs, cluster headache's bad enough because it's a rare disorder, but oh my goodness, new daily persistent headache, it's such an umbrella term. And so that's why I thought Shujun Wang's review article on it, if that's a really interesting paper that was published this year. So all the things I was presenting were things from this year. I thought that really put it into context. We need better definitions, better studies. But at the moment, we split it into tension type or migrainous versions. And so if there are migrainous features, we generally try off license the chronic migraine treatments. And there is a degree of success, so up to 50% in some trials, like a Botox case series, but they're not high-level randomized control trials. And the most recent ones haven't even separated out the chronic migraine from the persistent headache group. So it gets new daily persistent where it starts in one, in one moment that can be recalled. It started 728 days ago. It's quite different from chronic migraine that's gradually become persistent such that the person can't remember the last headache-free day. But they often get clumped together in the trials, which just makes it nonsense for specific treatments. But we do think that, and it's the same as medication overuse, there's significant overlap in the functional imaging and probable pathophysiological mechanisms underlying a migrainous headache disorder. And so we would use the same treatment. So that's why I thought it was useful to list off to the group that, we'd use blocks and Botox and preventives that are highly effective in this group still, if we can. But there's nothing new coming for that group specifically.
Peter asked about if there's any new research occurring regarding the gut microbes and the impact that has on people with migraine.
There might be. I don't hang out in all the right circles, so I'm not aware of it. I was looking these things up, and there is a link, but it's big studies I'm unaware of.
What Sharon wants to know, what aspect of migraine do you feel needs priority for further research?
Oh, what aspect? Well, I think right now there's a group that are CGRP responsive, and then there's the rest. So really, I agree with Christina Tassarelli's points that because she did the update of migraine this year, and that we really need to keep the basic science for new targets going on. And so, something will be studied for 10 years and come up at a dead end. But there are quite a few things of great interest that are coming along. PACAP is one of them. The orexins, which is involved in sleep cycle. It's really interesting because 12 years ago, I was sitting in a lecture by Peter Goadsby over in America, and he was banging on about this thing, CGRP, and I was like, yeah, tell me when it's clinically relevant. And here we are, and it's helped a lot of people who probably don't need to link in as much to these sorts of advocacy groups now to try and find that next thing. But there'll be a high proportion of the people listening tonight where what we've got currently is not adequate. And it's just tantalizing to see that there's these better treatments. And finally, we're seeing truly happy people, and you're realizing that they never wanted to take their analgesics. They never wanted to lie in bed. They wanted to have a healthy lifestyle. They wanted to work. But there's, some are so responsive, they do brilliantly, and that's their cause. But then what about the others? So I always think about, well, is it a sodium, potassium, calcium channelopathy? Because the nerves work with all these little channels that release neurotransmitters. Could something that's more global like Botox help? So there's lots of patients where I'll use combinations where they don't have an adequate thing, or go to that next thing that's a totally different mechanism. But we need more studies in those different mechanisms, I think.
Amanda wanted to know if we have if you have any suggestions for that online CBT that we could access.
Oh yeah, no, I don't. I'm not quite up to speed. So at the moment, I more suggest simple apps for relaxation techniques like Calm and Headspace. There's little podcasts where the story that nothing happens so you don't engage with it and you can fall asleep if sleep is a problem with a busy brain. There's a beautiful online sleep course, but it does cost some money, that's been written by sleep psychologists in this era where it's hard to access for all people. But as far as online CBT, so they did online mindfulness, which is a different thing. And so you can do the online mindfulness meditation relaxation strategies with Calm and Headspace locally, and you can choose the free version or to upgrade. So that's where I send people in Australia at the moment, but I'm sure Some clinicians have these things on their websites, but most of them are American. So, yeah.
Jennifer wanted to know a little bit more about biofeedback. We did a poll during this webinar and no one in the room had tried it. What is it and where do you go to get it?
Yeah, I was hoping this group could tell me. So this is the problem, right? So these are all things researched in largely America that are effective for a group. And who's doing it? Where are they doing it? How interested are they in the migraine subgroup? You know, as the president of the Headache Society, I don't know of a short list of places doing biofeedback specifically for migraine, unfortunately. So I mainly refer people for mindfulness, meditation, those sorts of things. Yeah.
Last question from Julie. She responded to your comment about PCOS and intracranial hypertension.
Yeah.
She said that she thought she had endometriosis potentially connected to her migraines. Has there been any studies on those?
Sorry, I missed the question. Sorry, PCOS.
Yeah, so she's got PCOS, endometriosis, and migraine.
Yeah.
Is there any connection there?
Yes, there's a big connection. So I actually always comment to because I start talking to my patients about their endometriosis, their uterine bleeding, the timing of their migraine, and they're thinking, why is this neurologist interested in my uterus? But the prostaglandin effects of having endometriosis, the iron deficiency that someone else asked about, are highly relevant to triggering more migraine attacks. So there's great interest in all of these things that are comorbid because, you know, we could rattle off so many things like hypermobility. There's a lot of other things too, rather than just the menstrually related endometriosis group. But I think they are relevant. As far as PCOS and migraine, I'm not aware of data looking at that. I think that question has probably never been robustly asked. So yeah, but I think there is a bit more metabolic syndrome in our group, and that's why being overweight is a risk factor, because it's not always a direct link. Sometimes it's, you know, sideways of what actually is the cause.
Excellent. Well, Dr. Jenkins, thank you so much for joining us tonight and doing this such an informative presentation and answering some tricky questions from the audience. I'm sure you know, I can speak on behalf of everyone here by saying that it was really helpful and I certainly learned a lot. So thank you.
No worries. Thanks for having me. And thanks for tuning in.
Yeah. And for those in the audience, we do have another webinar tomorrow with Francois Cadu from Migraine Buddy. We're going to be looking at some of the research from, I think it's tens of millions of migraine attacks. It's a crazy amount. They've got 3 million users on their platform. And I know that it's a public holiday, but it will be still going ahead for those that are interested. Would love to see you there. But for now, have a great night and thank you all again.